Hello and welcome to WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio-Menard. Hip dysplasia, a condition that can lead to partial or complete dislocation of the hip, is a relatively common condition occurring once in every 1,000 births. The tricky part is, while many are born with it, some won't show symptoms until they're teenagers or young adults with hip pain that limits daily functioning. But this doesn't mean you or your child are destined for a total hip replacement. Today we're talking about hip preservation surgery in teens and young adults with Dr. Andrew Parsons, an orthopedic surgeon at WVU Medicine Children's. Welcome, Dr. Parsons, to Tuesday Talks.
Thank you very much for having me.
We're happy to have you here. Now, if you have any hip dysplasia and hip preservation questions, just submit them in the comment section below and we'll try to answer them live. Okay, I think we have to start with hip dysplasia, obviously. What exactly is hip dysplasia?
So hip dysplasia is certainly a spectrum, but if you break down the word itself, dysplasia means abnormal growth, and the hip is made up of the ball, the femoral head, and the socket, the acetabulum. So any kind of abnormality in that relationship kind of falls under the term hip dysplasia. And we can see this ranging the entire age spectrum, from brand newborns all the way up to grandma.
So is it that it's just not lined up right? Things aren't in the right place?
So the way that the hip typically works is an absolutely perfect congruity between the ball and the socket. And with hip dysplasia, the vast majority of the time, there's a problem in the socket portion, or the acetabulum of the pelvis. And where you get problems is whenever you don't have appropriate coverage. The vast majority of the time that I'm talking about hip dysplasia, I'm always using my hands to be able to show that.
Okay.
And whenever you don't have appropriate coverage, that can lead to abnormal forces that are generated on the hip, which can eventually lead to subluxation, frank dislocation, or just abnormal forces that can lead to degenerative arthritis.
Oh, well, none of those are good. We know that. So what are the symptoms of hip dysplasia?
So with hip dysplasia, frankly, you can have no symptoms at all. As we said, you can see this in every single age range, but symptoms oftentimes would manifest themselves as pain with those abnormal forces between both the ball and the socket. That's eventually how they would manifest themselves.
Okay. But like you were just hinting at there, sometimes they don't show up until you're in your 20s.
That's exactly right. And that's one of the main reasons why screening for hip dysplasia is done in every single newborn child. Everyone who is born, they will undergo some sort of general hip testing. With hip dysplasia, we know that there are certain risk factors that put you at a higher probability of developing hip dysplasia.
Okay.
Those risk factors are being firstborn, being female, being breech position or foot first,
right,
and a family history. We kind of lovingly say the 4 Fs.
Okay, well, that's a good way to remember it. But I mean, so are you, is that the only way you get it? You're born with it? Or is this something that can develop later on?
It's really not something that develops later on. It's something that will kind of begin, and then you will later see the manifestations. But you appropriately use the term develop. We used to call this congenital hip dysplasia, which would mean that you were truly born with it.
Yeah.
But we have found kind of over time with looking at more studies that this is actually more along the lines of developmental hip dysplasia.
Okay. And you mentioned in the 4 Fs there that it is more common in girls and it can be hereditary, right?
It can. Hereditary, or more just in the sense that there's a genetic association with it. Not that I'm passing it on to my child. But we do know that this is something that you will see in families. Primarily, the statistic that we'll throw out is there's a 12% increased risk of hip dysplasia if one of your parents had it.
Okay. All right, good to know. So let's talk about treatment then. How do you treat hip dysplasia?
So hip dysplasia has a wide range of treatment. And the main way that you would determine that is based on the age of the child. As we said, you can have hip dysplasia in our newborns all the way up to our elderly population.
All right,
and
so
each one of them is going to have a tailor-made treatment.
A different treatment, yeah, because you mentioned this is a screening all newborn babies get. So what if they find out that your newborn has hip dysplasia? How do you treat it?
With hip dysplasia, number one, we would have to determine that it truly is hip dysplasia. So whenever anyone is born, we naturally have increased ligamentous laxity. In order for anyone to be born, mom essentially has to be a little bit more ligaminously lax.
Yeah.
And those hormones are still in the bloodstream of every single child. And after a little bit of time, things will tighten up. And the way that our hip normally forms is the normal muscular forces hold that femoral head in the socket, and it kind of makes a very good mold for it. And it essentially creates that perfect congruity. Whenever we have either increased amounts of some of those hormones, we can have a little bit of just normal subluxation or normal excess motion, which you might be able to detect at the very beginning. But after several weeks, that goes away and the hip should become stable. So whenever we are seeing these kids, we have to make sure that they're kind of out of that normal time frame when that ligamentous laxity and that seemingly loose nature of the hip isn't actually real.
Okay.
We would screen them at that time whenever we have concern for hip dysplasia with an ultrasound.
Okay.
At that time, the bones haven't ossified or fully formed yet that we can see them with x-ray. So we use an ultrasound to really determine if this is hip dysplasia, and if we have a shallow hip socket instead of more of the ball and socket, it's more of a ball and plate.
Oh, that doesn't sound efficient.
So if we did determine there was hip dysplasia at that age, one of the great things about it is we have a non-surgical treatment with a Pavlik harness. It's basically a harness that keeps a child in a frog leg position that allows that hip to sit exactly where it's supposed to be and create that good mold in association with the socket.
Okay. All right, that's like early on. Let's go to the other extreme, because this seems to be, is it more common that you have the symptoms when you're an older teenager or a young adult or even in your 30s?
Yeah, so that's oftentimes whenever we will have people present to clinic for evaluation of their hips, whenever they are having pain. As I mentioned earlier, there are a lot of people with hip dysplasia who don't actually have any pain. We get a lot of referrals to clinic based on what we would call incidental findings. They got an x-ray for something else, and what it showed is they did not have appropriate coverage of their hip. One of the interesting things about pediatric orthopedics in general is we do a lot of surgeries that are prophylactic or preventative in nature. Patients may not actually be having problems at all, but you're talking to them about doing interventions, whether they be surgeries or not, in order to prevent developing those problems later on.
And if you have these problems later on, you're probably going to need a hip replacement, right?
That can very well be the case.
All right, can we take this out now?
Yes.
All right, explain to us about this, the surgery. First, the surgery that you do for hip dysplasia is, I'm going to let you say it.
So it's called a periacetabular osteotomy.
Or PAO.
PAO.
Okay.
So peri meaning around,
Okay.
the acetabulum, which is the socket, and osteotomy means bone cut.
Okay.
So one of the main kind of ways that we would describe a periacetabular osteotomy is trying to give better coverage for the head. So whenever we look at a pelvis, the first thing we have to do is look at it appropriately as how we sit. or how we stand.
Yeah.
So it's not like this, it's actually
Like that.
like this. And you can see on a normal pelvis, you have a very good roof of the acetabulum,
Okay.
of the socket. So with a periacetabular osteotomy, if you have some sort of under coverage, what we do is we would make cuts in the acetabulum, and we would essentially rotate that piece of bone to give better coverage for the hip.
So it fits more correctly over the
Correctly.
ball joint.
Exactly.
Okay.
It's basically making sure that it has a good hat.
A good hat. Now, good hat's important. Well, I mean, so is the whole purpose of doing PAO surgery, and that's what I'm going to call it, is to prevent having to get your hip replaced at a young age or an older age?
That is essentially what it is. As I said, it's prophylactic in nature. Now, if you have developmental dysplasia of the hip, does that mean that if you have no intervention at all, you're guaranteed to have earlier arthritis? It's not, but it certainly increases your chances greater than 50%. So the normal population would develop hip arthritis after the age of 60. Those with developmental dysplasia of the hip who do develop arthritis, that's going to be happening earlier on in their 30s and 40s.
Okay, so when you do this surgery, it's mostly on like people in their 20s, 30s, and you said even 40s?
So that can be done at that age range. I'm certainly seeing more of the patient population that are in their teens.
Okay.
One of the prerequisites for this surgery is you have to be skeletally mature.
Okay.
There are surgeries that are done for developmental dysplasia of the hip in children that are still growing. This would not be one of them because these cuts that I just kind of showed, those are going through the growth plate themselves. So
wow.
you can't interfere with a child's growth.
No.
So that window that we're looking at a candidate for hip preservation surgery with a periacetabular osteotomy would be those who are skeletally mature but have not yet developed arthritis. If you have already started to develop arthritis and
too
we
late.
reorient that hip, you're still just reorienting a hip with arthritis.
Oh, okay, okay. But if you do, like say you're in your 20s or your 30s and you don't have arthritis yet by some miracle, if you go for this surgery and you're 25, 28, you go to Children's Hospital for the surgery.
We would
Let's
still
talk
do that.
about that because I think some people might be uncomfortable with that, but it kind of makes sense actually, doesn't it?
No, it certainly does. Though we do have a dedicated children's hospital,
Yep.
we just want to make sure that we're taking care of patients wherever they need to be taken care of. We have all the equipment there, and that's where we do these surgeries primarily. So even our adult patients, that is where we would do it. And if there are other adult expertise needed, whether it be anesthesia or nursing
Sure.
staff, that's something that we easily accommodate.
Yeah, yeah. So you shouldn't feel funny about having this done at Children's Hospital.
You shouldn't at all, and there are bright colors on the wall.
You're not a baby. Is there an ideal age for PAO surgery?
So there's not really an ideal age, but as we kind of said, the best time frame to have it done. And we know that the younger that you are, the better your recovery is going to be. And essentially, the earlier we can tackle this problem and still have good preservation of the normal cartilage or the cushion within the joint.
What's the recovery like from this surgery?
So it's essentially a 3-month recovery. It's going to be 6 weeks where you have limited weight bearing, your toe touch weight bearing or touchdown weight bearing, and then 3 months before we really let you get back to doing everything that you want. There's a lot of patients that we see who have dysplasia of the hip on both sides.
Oh, man.
So if we are to address both, we wait at minimum 3 months to allow them to have that one leg fully recovered and become the good leg before you talk about doing the next.
Okay, so no double
Could it be done?
yeah,
It
yeah.
could, but I
Why
think that
should
would be
you?
a little
Nah.
bit too much of a stress.
That would be a lot. That would be a lot. Now, to get a procedure like this, I think we need to point out, you don't have to leave the state or the region. We've got it right here. Talk about the expertise that you and your team have.
Well, you essentially said it right there. We really want to make sure that everyone knows that WVU has a hip preservation center, essentially. There are various tertiary care children's hospitals across the country that offer this procedure, and they are wonderful establishments with great surgeons. But we do have that here, and everyone wants to be able to stay closer to home for both their preoperative evaluations and their postoperative care. It's very important to us at WVU to offer the spectrum of care in every single pediatric subspecialty, as well as every other orthopedic subspecialty, just that all the major procedures we have under our roof.
Okay. And is it possible for somebody to go undiagnosed with hip dysplasia, not know that they have it, and not get, you really wouldn't get looked into until you had pain, right?
That's more commonly what we see,
Yeah.
that there are more and more people who were unaware that they had hip dysplasia, and we can see those patients at very young ages whenever they begin walking. But more commonly with our adult colleagues, we see those who are in their early 50s who have degenerative arthritis, and it turns out that they had undiagnosed hip dysplasia, which essentially wore out their hip.
Yeah. And you don't want that. We don't want that, that's for sure. What would you say then? Well, you did say the surgery is mostly done on young adults, correct? Mm-hmm. Is it ever too late?
So with the PAO, depending on how they might show up as far as the patient complaints or things of that nature, we would do various testing. One of the main indications for a PAO candidate is to show radiographic or X-ray evidence of hip dysplasia. We're not going to go into exactly what that shows, but basically under coverage of that hip. If we felt like there was evidence of too much arthritis, we might look at advanced imaging with an MRI, and that allows us to see not only the labrum, some of the other tissue around the hip, but it also helps us to evaluate the cartilage. And as I said, if there was too much cartilage damage or advanced arthritis, that wouldn't be a candidate that would be good for a hip preservation surgery.
Okay. So what would you say then for the people that are watching today? Oh, wait. We have a question coming in here. All right. Question from one of our viewers. How do you know if you have hip dysplasia if you have no pain?
You may possibly have hip dysplasia, but I wouldn't recommend that people just normally check. You would be evaluated with an X-ray, essentially. And that's not something that anyone should just be doing as a part of a routine medical screening.
It's not a routine screening, yeah.
As I said, our newborns, they are routinely checked by all the pediatricians.
Right.
And that is where we are going to catch the majority of them. But anyone in the adult population, if you're not having any hip pain, I don't think it's something that you should just be looked at.
All right, so what if you're in your 20s or 30s and yeah, you are having hip pain and it's getting in the way of, your daily routine and functioning? Who do they call? I mean, well, you, of course, but I mean,
So
the pediatrician.
That's a very good question, because if you're saying that you're in your 20s or 30s,
Yeah.
you're not going to be calling your pediatrician.
No.
You're going
No.
to be calling your primary care physician, and they will be most likely bring you to the adult orthopedist. And the adult orthopedist, they may be the one who contacts me. We have several partnerships, so to speak, with some of our adult joint surgeons and some of our adult sports surgeons, that if there is a concomitant procedure that needs to be done, say a periacetabular osteotomy, but also a labral repair, that can be something that can be done at the same time with our sports surgeon as well as with myself.
Okay, good to know. All right, so for people that are watching now, what's the most important thing you want our viewers to know about hip preservation surgery and hip dysplasia?
So I would certainly want them to know that hip dysplasia, as you said earlier, is very common. And it's also very scary.
Yeah.
It's something that a lot of people don't know a lot about. And there's a lot of resources available online, but making sure that they know that those resources are also available in person for correct evaluation, diagnosis, and treatment here at WVU.
Right here in our front yard, as I always like to say. Not our backyard, it's in our front yard. It's here. Well, thank you so much for sharing all this information with us and bringing props. Props are always a plus. I love it. Thank you for that. And I hope we've helped a lot of people out there today.
I certainly hope so.
All right, thank you. That brings us to the end of this edition of Tuesday Talks. If you're looking for more information about hip surgery, visit wvumedicine.org/ortho. And join us on Tuesday Talks on May 9th when we'll talk about stroke awareness with Dr. Muhammad Alvi, a neurologist with the Rockefeller Neuroscience Institute. I'm Mary Ravazio Menard, and on behalf of Dr. Parsons and everyone at WVU Medicine, thanks for joining us and have a great day.